there, convener of the session, Dr. Gazelle Bruce Warji, madam. Myself, Dr. Swaraj Bhattacharjee, chairman. Then Dr. Amal Raja Luis is not there. And I like to request our Purvi madam, Purvi Bhagat madam. You can come this side, madam. Please. Madam के लिए का- One point. So our first presenter is Dr. Manisha Barik. The topic is a study on the visual outcome in patients with a lens-induced glaucoma following SICS. She's not there? Okay. Next, Dr. Jyotish Khillar. Yes. The topic is surgical outcome of MMC augmented NPDS and phacoemulsification in eyes with end-stage glaucoma.
Thank you, judges. My topic of presentation is visual and surgical outcome of mitomycin C augmented combined non-penetrating deep sclerectomy and phacoemulsification in eyes with end-stage glaucoma. So NPDS is an ab externo filtering surgery. It enhances aqueous outflow by excising external trabecular tissue and inner wall of Schenck's canal. In advanced glaucoma with split fixation, trabeculectomy may pose a high risk of macular snuff out. NPDS being a non-penetrating surgery could be safer alternative in such eyes to avoid vision loss due to macular snuff out. Very few studies compared the both and none have recent data. So it's an approved retrospective observational study in a tertiary eye care hospital where 349 eyes of 324 patients were studied in between 2018 to 22. All surgeries were done by same team of experienced surgeons. Under inclusion, age more than 18 year, open angle of POAG, pseudoexfoliation glaucoma, primary angle closure glaucoma with superior open angle, severe glaucoma with significant cataract and HFA showing split fixations were included. Under exclusion, the eyes with standalone NPDS, poor visual acuity, not amenable to perform fields, unreliable visual field, intraop complication with NPDS deferred, and previous intraocular surgeries and any media opacities are excluded. In preoperative evaluation, BCVA, IOP, slit lamp examination of vertical cup disc ratio and gonioscopy and HFA 10-2 were recorded before surgery. In surgical method, after injection of mitomycin C, a superficial scleral flap of 5 into 4 mm rectangular with uniform depth were raised till clear cornea with deep 4 into 4 mm scleral flap cautiously, followed by dissection of trabecular descendant membrane and scleral tissue, deep scleral tissue resected. The end point is the seepage of aqueous humor, followed by closure of scleral and conjunctival flap, and finally the clear corneal temporal phacoemulsification. So in post-operative care, antibiotic and steroid drops have been given in tapered manner for 12 weeks, cycloplegic for 4 weeks, and post-operative maneuvers like laser goniopuncture and bed knitting for bleb survival has been done. In follow-up was done in day 1, 14 days, month 3, 4, 12, 18, and 24, in which BCVA, intraocular pressure, number of AGMs were recorded in every visit. Visual field in 3, 4, and 3, 6, and 12 months, intra-op and post-op complications and intervention and occurrence of wipeout phenomena were noted. So in results, this is the demography of study participants where POAG recorded the majority with 62.8%. Here you can see in visual acuity, there is significant improvement in visual acuity with stabilization in subsequent follow-up visit. Similarly, in visual field also there is stabilization compared to baseline. So our primary outcome measures based on visual field, which gives a success rate of 93%. So in terms of intraocular pressure and number of AGM, there is significant results in follow-up visit over a period of 2 years. It contributes in secondary criteria for success. In complication, we recorded highest with refractory raised IOP in 29 eyes. We have additional procedures like AGV, RD, and diode cyclophotocoagulation in 5 patients. So we observed a 93% success in 24 months based on visual field stability. Also, There is significant improvement in visual acuity, reduction in intraocular pressure, reduction in need of AGM, minimal intra and post-op complication, and fewer intervention. Previous reports compared trabeculectomy with NPDS have lower risk post-operative vision-threatening complication like hypotony, maculopathy, choroidal detachment, shallow anterior chamber, etc. We recorded only one patient with choroidal detachment which spontaneously resolved without any intervention. Previous literature shows a risk of wipeout phenomenon in an invasive procedure in a range of 13.6%. We do not encounter any such phenomenon. Intraoperative use of MMC in NPDS was less reported earlier. We observed a significant IOP reduction and reduced need of AGM, which relate to the use of mitomycin C injection. The long-term survival of NPDS depends on maintaining the intrascleral space. In our study, we believe it's because of MMC. So eyes with advanced PSCG are generally at greater risk for any penetrating surgery, and with NPDS, this risk may be minimalized. So we have included a subset of high-risk PSCG of around 51 eyes, where we observed no vision-threatening complications. So limitation, we missed ASOCT assessment of bleb morphology due to retrospective nature. No subgroup analysis has been done. And in strength, our study has a large sample size with long follow-up period of 24 months, exploring the efficacy of mitomycin C in NPDS. And inclusion, we have included PSCG and pseudoexfoliation. So MMC augmented NPDS is combined with phacoemulsification surgery is a safe and viable option in eyes with advanced glaucoma with post-operative stabilization in visual acuity and visual field. Thank you.
Next person we have is Dr.
So, very good study, but further in the future, if you want to do any other studies, you can compare with phaco-trab.
Yes.
Next author we have is Dr. Gauri Gatani. Unexpected visual recovery post-trabeculectomy in case of one-eyed patient with refractory glaucoma. Maximum we'll ask only one question. Paucity of the time.
Good afternoon, everyone. So the case I'll be presenting today is an unexpected visual recovery in a one-eyed patient with refractory glaucoma. So I present it not only out of academic interest, but also because it still remains to be an enigma as to how visual recovery happened in this case. So a 66-year-old female presented to the OPD with complaints of severe pain and loss of vision only in the left eye since last few days. On examination, I found out that she had undergone trabeculectomy 6 years ago before presentation, and also cataract surgery in the right eye 3 years before presentation. And right eye was on presentation thicycle. So on examination of the left eye, the best corrected visual acuity was just finger countings at around half meters. IOP couldn't be recorded with non-contact tonometer or tonopen. So, but it was very hard on palpation. And the anterior segment showed clear cornea, clear lens, a non-reacting mid-dilated pupil, and an old cystic bleb of Prab located superiorly, and a very shallow OC. But on gonioscopy, I found the angles to be open. The fundus examination showed a 0.8 cupping, while the central fundus was grossly within normal limits. So after few days, when the pressure was brought under control, these investigations were done, and anterior segment OCT showed an anterior segment anterior chamber depth of 0.68 millimeters and a right and left angles of 30 and 24 degrees respectively. Also, the pachymetry showed a very low central corneal thickness of around 367 micrometers. This is the left eye RNFL thickness, and the peripapillary RNFL area is very thinned out around 52 micrometers. So what we did was, on the first day of presentation, we started full topical and oral and IV glaucoma treatment with IV mannitol 200 cc, tab Dimox to start, and topical treatment of timolol, brimonidine, brinzolamide, latanoprost, and pilocarpine. And after few days within of follow-up visits, the pressure first came down to 55 as shown in the graph, and later the treatment continued over 10 weeks, and this is the graph that despite full topical treatment and oral treatment also, her pressures varied between 11 mmHg to 35 mmHg, and there was absolutely no visual improvement, though she got relief from pain. And she was unable to perform daily activities being one-eyed, so we decided to go ahead with a repeat mitomycin C augmented trab in the left eye to achieve a lower target pressure. and surgery was performed 10 weeks after presentation. So these are the intra-op things. We made a limbal-based conjunctival flap, and 0.2 milligram mitomycin was applied. Sclerotomy was done, iridectomy done, and sutures were taken to secure the triangular flap. We found that there were extensive conjunctival adhesions in that area due to the previous surgery. So I had to take an inferior conjunctival graft to cover the trabeculectomy site with glue. And but tight closure was achieved that day. On post-op day 1, there was hypotony and choroidal folds could be seen, but sedals was negative. And on the following post-op visits, I was surprised to find that the BCVA improved to around 612, and the pressures were very good maintained. The bleb was functioning, well-formed AC, and this is the post-op picture. Superiorly, there is the old cystic bleb, and superomedially is the new bleb with the conjunctival graft over what we made. And this is the fundus photo of post-op around 4 weeks. And these are the findings of post-op 4 week. There was no significant change in either anterior segment depth or the RNFL thickness. She was able to perform HFA 30-2 as well as 10-2, and these were the findings. So with my research I could found out was that RGC death mechanism is biphasic, but so even after a primary insult of increased IOP and vascular deregulation, there is a period of reversible secondary cell degeneration, where if you control the IOP, there might be restoration of exoplasmic flow and improved microcirculation, and which might have caused the reversal of visual acuity, but this has been proved only in the congenital and juvenile glaucomas as yet. So in conclusion, I would like to say that reduction in IOP not only had a neuroprotective effect, but also a neuroenhancing effect in this case, and which I suppose is due to the restoration of exoplasmic flow and improved microcirculation to the optic nerve. Thank you.
So very interesting case. So why was Goldman GAT not done for IOP? You said NCT was not.
Not on the first visit. I couldn't. First visit, she was not cooperative, ma'am. She was very in too much pain. On the follow-up visits, I had done, ma'am, and I've documented over the next 10 weeks.
So do you think the optic disc and visual field are correlating, according to you?
Yeah, the thinning was around 0.8 to 0.9, and visual
But you
field
said NRR was healthy.
NRR seemed vague. Ma'am, it did seem healthy.
So it has to correlate.
Yeah. I even got an MRI done in this case, which I haven't included, and it came out to be normal to rule out other causes.
And why was 10 weeks the waiting time for surgery when she's one-eyed with very high pressure?
Because she was already trabeculectomized, ma'am, and that's why I didn't want to touch the patient. And there was hardly any area where I could see that I could operate. So ultimately, I went for a superomedial site, and I had to take a graft inferiorly to cover that area. Thank you, sir.
Thank you, Dr. Gauri. I would now invite Dr. Saloni Joshi for a presentation on paradox in the eyes, a case of bilateral acute secondary angle closure glaucoma.
Good morning. Today I'm going to present an interesting case which can be easily missed in an OPD setting. It's not coming. Paradox in the eyes, a case of bilateral acute secondary angle closure glaucoma. A 66-year-old male presented to OP on 12th of October with sudden painless diminution of vision in right eye. He was a diabetic since 3 years and a hypertensive patient since 1 year. On examination, he was diagnosed to have rhegmatogenous retinal detachment in right eye, and the left eye had brown cataract. He was taken up for RD surgery, and after initiation of surgery, a break with subretinal hemorrhage was noted at macula, which was suspected because of peribulbar block-induced perforation, and it was drained to the maximum. Otherwise, the surgery was uneventful. Prone position was advised, and routine post-op medications were advised along with tablet astazolamide for 5 days. The next day, to our surprise, the visual acuity in left eye had decreased. The IOP in both the eyes was high. There was conjunctival chemosis in both the eyes, and the anterior chambers were shallow. Gonioscopy revealed closed angles in the left eye. And so a glaucoma referral was made. B scan was done, which revealed an oil-filled globe in right eye, and left eye showed shallow CDs. We thought that the right eye findings were because of the RD surgery, and in left eye, considering CDs, shallow AC, and high IOP, we considered the following differentials, which is VK8 syndrome, uveal effusion syndrome, and sympathetic ophthalmia, since there was an iatrogenic trauma. But these were ruled out clinically. And we came to a probable diagnosis of some form of secondary angle closure. PI was not done due to CDs and inflammation, and the patient was started on maximum possible anti-glaucoma medications. Tablet acetazolamide was continued, and rest of the post-op medications were continued. But on POD2, the IOP had further increased, the conjunctival chemosis had also increased, and the anterior chambers were now totally shallow with 360-degree iridiocorneal touch. So here, and the B scan was repeated, which shows a worsening of CDs. So here we have a patient who presented to us on POD1 with CDs, shallow AC, and increased intraocular pressure, which worsened on POD2. So a cross opinion from a senior medical officer was taken, and the diagnosis was revised to oral acetazolamide-induced acute secondary angle closure. Since this is a bilateral condition, we thought that the CDs in right eye may have been masked because of buccal effect. The tablet was discontinued immediately, and rest of the medications were continued along with anti-glaucoma medications. On POD3, the vision was improved, the IOP had also decreased, and the conjunctival chemosis had reduced. So we discharged the patient with anti-glaucoma medications, and he was asked to review after 5 days. When he reviewed, the IOP was now normal. The conjunctival chemosis had also decreased, and the anterior chambers had started forming well. When he came after, the B scan was repeated, and it showed that the CDs were resolving well. When he came after 3 weeks, the IOP was completely normal, and anterior chambers were also well formed. So the AGM were stopped. So what's different in this case? Even though it's not uncommon, it can be easily missed. It is an idiosyncratic reaction to acetazolamide, though topiramate-induced angle closure is more common. It is a paradoxical simultaneous bilateral acute angle closure due to choroidal effusion, and it always occurs after the initial priming dose. The first dose will be the sensitizing dose. Timely withdrawal of the offending agent is a must. Topical anti-glaucoma medications can be given to control IOP. Cycloplegics will help to alleviate the pain as well as form the anterior chambers. Steroids can be given to control the inflammation. YAC-PI should not be done, and myotics are avoided as they further increase the blood aqueous barrier breakdown breakage. So various case reports have been noted in literature, and mostly all are noted after cataract surgery. It's indeed a strange paradox, because the drug which is used to treat IOP ended up causing the same. It is an ophthalmic emergency, and the fine line between acute primary angle closure and acute secondary angle closure has to be differentiated, since the treatment management is entirely different. Pilocarpine and PI have to be avoided in these patients. Patient education about warning symptoms like blurring of vision, conjunctival chemosis, halos can be given, and also the doctors should be made aware of the set of drugs leading to idiosyncratic reactions. Thank you.
I had only one query. Usually in a silicone oil filled eye, you don't get B-scan images of posterior segment. B-scan in silicone oil filled eye is not very easy, and you are giving your pictures are crystal clear, so I'm a little surprised with that.
Also, you could have done one non-contact, a contact procedure in the other eye, which could have helped you in diagnosing. Can you think of any investigation that you could have done?
ASOCT.
That is non-contact, contact. UBM.
UBM could have been done. Thank you.
Now we'll call Dr. Mohammed Akbar. comparing posture changes of IOP in normal and glaucomatous eye in Indian population.
Very good afternoon, judges. My title is Comparing Posture Changes of Intraocular Pressure in Normal and Glaucomatous Eye in Indian Population. In increased intraocular pressure has been identified as an important risk factor for the onset and progression of glaucoma. Posture is one factor that has longer effect on the intraocular pressure. The posture changes from the sitting to the supine can increase intraocular pressure significantly with this IOP. Fluctuations suggested to be related to the structural and functional deterioration in glaucomatous eye. Primary open-angle glaucoma is the most predominant type of the glaucoma in the world. It is well known. Among other risk factors for primary open glaucoma, rise intraocular pressure is the commonest, and at present, the only risk factor that can be modified is the IOP. M is posture changes in intraocular pressure in normal and glaucomatous eye of Indian population. The objective is to assess posture changes in the intraocular pressure in the normal and glaucomatous eye of the eye. The study material is a case control study. It is carried out at Tertiary Care Hospital in Western Maharashtra. The sample size is around 60, total 60. 30 group 1 is the 30 subject for primary open glaucoma and 30 for the normal eye. The position is parameter is sitting with supine flat position and sitting with supine with pillow and supine flat with supine with pillow. The inclusion criteria is for the primary opening glaucoma is open interchamber angle. There is SAFA grade 3 and 4 in all the quadrant, and there is a rise intraocular pressure greater than 22 mm of Hg, and vertical cup disc ratio of about greater than 0.6 mm or symmetry asymmetry of the disc cupping equal to or greater than 0.2 with or without the flowing disc changes, a rim notching or thinning of the rim, disc hemorrhage or violation of the ISNT. To rule out dilated fundoscopy by using the 90D in on both eye. And characteristic glaucomatous visual field defect, there is nasal steps, paracentral scotoma, or double arcuate decodum by using the Humphrey visual field analysis. For normal eye, there is non-glaucomatous patient. Vertical cup disc ratio is less than 0.6, and there is no disc symmetry of less than 0.2. There is no rim notching or thinning of the rim, no disc hemorrhages or violation of ISNT rules, and the IOP should be less than 22 mm of Hg after pachymetry. Exclusion criteria: there is a participant is participant is greater than 30 years and diagnosed with POG before the studies, and types of glaucoma other than the glaucoma POG, and previous ocular surgeries, intersegment pathologies such as acute and chronic uveitis, any corneal abnormalities that will prevent reliable of IOP measurements such as corneal opacity to be ruled out, diabetes, hypertension, and subject on medication which is known to influence the IOP to be ruled out. A case control as match study was conducted in 30 successive newly diagnosed POG and 13 normal eye, and the IOP eligible correspondent one measure with Parkin's hand tonometry in the sitting position, supine flat position, and supine flat with pillow position respectively. Measuring of IOP in this position was done after 15 minutes of assuming each such posture. The results, the IOP differences between the sitting and supine flat positions was significantly higher in primary open glaucoma than normal subject. That is 5.06 plus minus 0.9 versus 6.01 plus minus 0.8. The p-value is less than 0.001, which is very significant. The IOP difference between the sitting and supine with pillow position was 1.36 plus minus 0.14 for primary open glaucoma and 2.8 plus minus 0.34 in non-glaucoma. And the p-value is 0.001, which is also significant. The difference between the supine flat position and supine with pillow position plus was 3.7 plus minus 0.23 in primary open glaucoma and 3.2 plus minus 0.51 mmHg in normal patient. The p-value is 0.001. And this is this graph shows that the blue one is the newly diagnosed primary open glaucoma, and the red one is normal eye, which is very significant in the graphs. And here, this is the IOP, is the lying position with pillow in the newly diagnosed primary open glaucoma, and the red one shows that this is lying with pillow with normal eye. The same here. And to be conclusion, greater variation in the posture-induced IOP occur in primary opening glaucoma patient than non-glaucomatous. The posture-induced IOP variation is the lowest in the sitting position and highest in the supine flat position. Evaluation of posture-induced IOP changes may be important tool in the management of glaucoma. Thank you.
Thank you. I'd like to ask you, in this situation, you just advise to the patient to avoid the pillow. You cannot allow, you have to allow the patient to sleep in a supine position, but pillow can be avoided in the case of glaucoma.
Yes,
that is the only clinical came out.
Yes.
So were they on any medications, these patients?
No, sir.
No
Any
medication.
medication.
So same day diagnosed, same day visual field,
Yes.
gonioscopy,
Yes.
dilated exam also was done on that day.
Yes.
So IOP on after dilatation may vary then.
Pardon me?
IOP after dilatation
Yes,
may
ma'am.
vary, that means.
There is variation, ma'am, actually.
So you may have to write that in the drawbacks. No?
Yes. ma'am.
Why did you not include the standing postures?
Actually, ma'am, standing person might be due to some hypertension. There may be posterior hypertension also may be there. So it is better to be avoided, sir. Actually.
Fine.
Thank you.
Next is the safety and efficacy of subliminal cyclophotocoagulation in the treatment of glaucoma. The presenting delegate Dr. Priyanka Ramanathan.
Good afternoon and all. I'm Dr. Priyanka. I'll be presenting on safety and efficacy of subliminal cyclophotocoagulation in patients with glaucoma. Subliminal cyclophotocoagulation is one of the latest technology that uses 810 nanometer diode laser, which is non-destructive. It consists of series of highly brief microsecond pulses on the targeted tissue with a minimal collateral damage. It helps in reducing the drug burden for the patient and evidently improves the quality of life. It also has an added advantage of easy application with improved and focused energy delivery and reproducibility of the outcome. So based on the pulse technology, there's something called as duty cycle, which provides cool-off period between the pulses. So during the on time, the laser will be acting on the targeted tissue, but in cool-off period, it allows the tissue to cool, so there will be reduced collateral damage. So it eventually eliminates the risk of overheating. So it reduces the collateral damage and minimizes complication, and there is no direct impact on the vision. So in this procedure, we use certain parameters with a fixed duty cycle at 31.3% with a treatment duration of 160 seconds. Superiorly, we use 80 seconds, and inferior quadrant we use 80 seconds with a power of 2000 milliwatts. This is the parameters that is shown in the device. So the tip of the probe is positioned at 3 mm posterior to the limbus and perpendicular to the eyeball. So the probe tip moves continuously in a sliding motion, so superior and inferiorly, avoiding the 3 and 9 o'clock position to prevent the damage to the ciliary nerve block while delivering the laser treatment. So in our study, we took 27 patients with various indications of glaucoma, most common being the primary open angle glaucoma, followed by angle closure and ocular hypertension. So median pre-op IOP was 22, and with the average number of medication was 3. With most of the patients had poor visual acuity. Some patients, only 3 patients who had poor visual acuity, 2 is because of the cataract and 1 is because of the traumatic aphakia. These patients underwent a subliminal cyclophotocoagulation. Post-operatively, patient was followed up for 6 months, and complications were noted at each follow-up visit. So this first graph shows the trend of IOP reduction post-operatively over the time compared to the pre-op. So the study result shows that IOP reduction was noted significantly at each time point. And the second graph shows the trend of reduction of anti-glaucoma medication comparing the post-op and the pre-op. So the dip in the graph corresponds to the maintenance of the IOP during this time. When the anti-glaucoma medications were further lowered, it causes the rise in IOP, which is seen in the first graph. So eventually the laser reduced at least one topical anti-glaucoma medication in 61.5% of the patient at 6 months compared to from the baseline. So these are the various complications that were noted in our study, most common being the anti-tumor reaction and the mydriasis, but both were transient and spontaneously resolved over the time. So these three complications that were dreaded and which was observed in the study, we will see one by one. The first complication, which is vitritis, was noted in one of the patient who had diminution of vision, sudden onset at 1 week follow-up visit. Fundus examination showed grade 4 vitritis, which is confirmed by B scan. It was managed medically with oral and topical steroids, and she regained 6/6 vision in 1 month. The second complication, a patient developed a hypotonia of 6 mm Hg at 1 week follow-up visit. We stopped all her anti-glaucoma medication. Despite that, she had a corneal detachment at 1 month follow-up visit. Even for her, we managed medically with the oral and topical steroids. No surgical drainage was required, and she regained her full pre-op vision at the end of the 1 month. The third complication, the patient who already sustained a blunt ocular trauma with closed globe injury underwent vitrectomy surgery and was left aphakic. Post-surgery, he had a high IOP spike, and it was not controlled by maximum medical treatment. So he went the laser procedure. Post-operatively, he developed vitreous hemorrhage at post-op day 1 and with a moderate control of IOP. So we could also see the Eifelman slit lamp, and vitreous hemorrhage was confirmed in B scan. There was also transient reduction in visual acuity for 55% of the patients initially, but later 80% of the patient regained their pre-op vision post-operatively in the late post-operative period. Finally, the cumulative success was found to be 83% at the end of the 6 months. So these are the various studies that showed different complications, but none of the studies have reported complications like vitritis, corneal detachment, and vitreous hemorrhage, which were seen in our study. Concluding, subliminal cyclophotocoagulation is a viable option for patients with mild to moderate glaucoma with maximum medical therapy. The major advantage of this laser was that it can reduce the burden for the instilling topical medications for glaucoma patients. In most of the studies, it was found to be safe, and however few vision-threatening complications can occur, but these complications can be transient and treated with medical management. Thank you.
Thank you for that presentation. Could you identify any risk factors for those rare complications that occurred with your treatment?
None of the patients had any risk factors. Only the last patient who had traumatic aphakia, who had closed globe injury, we could have avoided this laser procedure for him. It actually led to vitreous hemorrhage.
So does the amount of energy delivered or the areas treated matter? Do you think so?
For every patient, we had the fixed amount of energy, that was 2000 milliwatt, and fixed duration is 160 seconds. So only the spots is also it's equal because it is superior continuous and inferior is also continuous.
Thank you.
Next speaker will be Dr. Sushil Ojha. Perspective interventional study of SLT in lowering IOP in POAG and OHD in Indian eyes.
He is not there.
Dr. Sushil not there. Then we'll call Dr. David Jose Matthew. Cytokine signatures in glaucoma and extensive comparative analysis. Not there. So Dr. Supriya Sri Ganesh, a triad of signs to confirm successful implantation of a trabecular microbypass device.
Good afternoon, judges. A very good afternoon to the judges. Today I'll be talking about a triad of signs to confirm the successful implantation of a trabecular microbypass device. In recent years, microinvasive glaucoma surgeries offer lower medication burden and complication rates. Today we'll be speaking about the iStent Inject. It's composed of titanium and has a characteristic head, measures 360 microns in length to 30 microns in width, and contains 4 inlets for the passage of aqueous. The narrow body contains the lumen. The head sits within the trabecular meshworks, and a flange secures the device on the inner wall of the meshwork. The injector has 2 preloaded stents at a time, and it provides the ability to insert multiple stents while entering the eye only once. This paper aims to discuss the guidelines to implant the device and its correct position for optimal functioning, and we have described a triad of signs which can be used as a tool for assessing the successful implantation. Now, 16 eyes of 13 patients with mild to moderate open-angle glaucoma underwent phaco with iStent inject implantation. Inclusion criteria was patient above the age of 18 with open-angle glaucoma on 1 to 2 anti-glaucoma medications with the need for cataract surgery with visual acuity of 660 or better. Patients with angle closure traumatic glaucoma, uveitic glaucoma, congenital, etc. Were excluded, and any patients with active corneal dystrophy or opacities that would impair the stent visualization and placement, and any other pathologies apart from cataract and open angle glaucoma were excluded. Now, the surgical procedure, the pupil is constricted with the pupil is in pupil is constricted with pilocarpine after IOL implantation. 2% sodium hyaluronate is used to maintain the chamber. The sleeve is withdrawn after entering the AC. The trabecular meshwork is identified with the blood in Schlemm's canal. The trocar is placed in the trabecular meshworks, indented slightly, and the button is pressed on the injector to inject the iStent device. And without releasing the button, the injector is withdrawn and the button is released. The ooze of blood after injection indicates that the iStent is in the Schlemm's canal. The steps are repeated for the second site. Pressurizing the eye or over-pressurizing the eye will lead to a blanching effect on the conjunctiva, which is described as the blanching sign, and intraoperative OCT is used to look for an accumulation of fluid under the conjunctiva called the fluid lake sign. So these are the 3 triads which we will be demonstrating here. So here, as you can see, the direct gonioscope which is provided is used to visualize. After injection of the iStent, there is an immediate ooze of blood, and this is the first sign which is described. This is the second device which is implanted 2 to 3 clock hours apart. The second sign is on over-pressurizing the antechamber. Just notice the blanching of the superior blood vessels. This is called the blanching sign. The third sign is the fluid lake sign on intraoperative OCT. Here you can see it goes from an area of, not the area of iStent implanted. So the conjunctiva there was quite flat, and here this is the area of the iStent implantation. So the conjunctiva is wavy, and there is fluid accumulation under the conjunctiva. This is only on over pressurization and it is attributed to a leak from the veins. So the results in the 16 eyes, here we see that the preoperative IOP in 10 of those eyes was less than 18 mm of mercury, and in 6 of those eyes were more than 18 mm Hg. And the mean IOP reduced after iStent implantation. On post-op day 1, there was a spike. The mean increased from 16 to 19. On post-op 1 week, it came back down to 17, and on post-op 3rd week, it came down completely to 15 and stabilized over 3 months to 6 months and came down to around a mean of 14 millimeters of mercury. Here we can see 2 of the patients in which we did not see all the 3 signs. Only the first sign was observed, where there was a mild ooze from the site of implantation, but the second and third, the blanching and fluid lake sign, were not seen. And in these 2 patients, we see that there was no significant lowering of IOP after the iStent implantation. And this is the same thing that we see. 14 of the patients were taken off all anti-glaucoma medication. 2 of the patients had to be put on 2 anti-glaucoma medication even after the iStent implantation. These were the outcomes. And to conclude, I would like to say that this indicates that the triad of signs is a reasonable marker for accurate placement of the iStent. Thank you very much.
Thank you very much.
Last, we invite Dr. Hitisha Mittal, she's there, for the presentation on rescuing conjunctival lymphatics from MMC-induced damage in rat model of glaucoma surgery.
Good afternoon, everyone. I'm Dr. Hitisha, and I will be sharing our work on rescuing conjunctival lymphatics from mitomycin C-induced damage in rat model of glaucoma surgery. The draining vessels from the conjunctival blebs are damaged during glaucoma surgery due to inadvertent cutting of the vessels, due to usage of intraoperative cautery, and foremost by usage of mitomycin C intraoperatively. It not only damages the pre-existing channels but also prevents reformation of these channels post-operatively. A study published in 2021 used ocular surface lymphangiography in live humans and showed the presence of lymphatic channels in the subconjunctival space. Another study published in 2016, they saw the effect of mitomycin C on the density of blood and lymphatic channels in eyes with leaking blebs post-MMC trab, and they found that there was a significant reduction in the blood vessel and lymphatic vessel density in the MMC-treated eyes, suggesting its toxic effect on these draining channels. So this leads us to defective fluid removal from the subconjunctival space, eventually causing bleb failure. This led us to this question: can we induce lymphangiogenesis in the subconjunctival space, especially after MMC application? On further literature search, we came across retinoic acids, which have been evaluated in different studies of animal models for their lymphangiogenetic potential and saw that they have positive lymphangiogenic role. So we designed a study with the aim to see the effect of MMC application on the conjunctival lymphatics and to see the reversal of this MMC-induced inhibition of lymphatics by simultaneous application of retinoic acid. It was a prospective experimental interventional study done on 25 Sprague Dawley rats after appropriate ethical approval. We had 25 rats divided into 5 groups. The right eye in all the groups was the intervention eye and the left eye was control. We used a 30 gauge needle to induce subconjunctival injury in the right eye of all the rats, followed by a superior subconjunctival bleb formation according to each group specification. In group A, the bleb was formed using balanced salt solution. In group B, using mitomycin C. Group C, 100 nanomoles of the synthetic retinoic acid. Group D was the combined MMC and retinoic acid group. And group E was the dimethyl sulfoxide group, which is a diluent for the retinoic acid preparation. On postoperative day 14, the eyes were renucleated, the conjunctival specimens were excised and sent to pathology for staining with Mason trichome, CD31 and D240, which are the vascular and lymphatic endothelial markers respectively. And we aimed to see the fibrosis, lymphatic and vascular density in these channels. Now coming to the results, these are the histopathology slides of D240 stained specimens showing the lymphatic channels. The first image shows the normal conjunctival tissue and the arrows marked shows the lymphatic channels. The second one shows there's an increase in the number of lymphatic channels after a localized injury with balanced salt solution. The third image shows a decrease in the number of lymphatic channels when MMC was applied. And the fourth image shows a dramatic increase in the number of lymphatic channels when there was a combined usage of MMC and retinoic acid. This table highlights the fact that the mean lymphatic count was higher in the combined MMC and retinoic acid group as compared to the MMC group alone. The first graph shows the intra-group analysis between the intervention and control eye of across all the groups. It shows that the MMC treated group had a lower lymphatic count in the intervention eye when compared to its control, and the combined MMC retinoic acid group had a significantly higher lymphatic count when compared to its control. Similarly, on intergroup analysis, we saw that the combined group had a higher lymphatic count compared to the group A and group B. So, MMC resulted in significant reduction in conjunctival lymphatic density. The 100 nanomole retinoic acid significantly increased the conjunctival lymphatic density not only when used alone, but also in the MMC treated eyes. So we conclude that synthetic retinoic acid prevents MMC-induced reduction of lymphatic vessel density in rat eyes, and it has potential application in preventing or reversing the MMC-induced complications in glaucoma surgery and thus improving our surgical outcomes. Thank you.
Thank you very much. And what was the time between the injection of the solution and the sacrifice of the animal?
So 14 days. There's a Singapore eye model for glaucoma surgery, and they have found that the post-op day 14 shows similar wound healing properties when we compare it with human studies. So that's why we chose post-op day 14.
So I think with this we come to the end of the session.
Thank you so much.
I'd like to thank all the chairpersons, the presenter, and the audience who are with us till the end. Although lunch, people are waiting for the lunch to start. Before just to end up, a small photo session with the presenter and the chairpersons. You have, no, it was your name? Okay, okay,
He has come late.
you have come late actually, you have passed on. Never mind. Please, please.
Thank you and good afternoon. Thank you for the opportunity for letting me present. I have no relevant conflicts of interest to disclose. The purpose of the study was to characterize the aqueous humor in primary open-angle glaucoma patients and correlate the findings with disease severity. So overall, we had 3 groups: controls without glaucoma, mild glaucoma, and advanced glaucoma. The idea was to sample aqueous humor from all these 3 groups with an N of 10 in each group. After getting ethics board approval from the 2 participating centers, informed consents were obtained from all participating patients, and the staging of the glaucoma was based on the mean deviation values. The aqueous humor collection was done with a 30 gauge needle mounted on a 1 ml syringe, and 100 microliters of aqueous was withdrawn from the anterior chamber. The glaucoma samples consisted of primary open-angle glaucoma eyes, mild and advanced disease. Control samples eyes did not have glaucoma. We excluded patients who had prior ocular surgery and those with ocular inflammation. After collection of the samples, these were frozen on dry ice and then stored at -80 till the final analysis. The final analysis panel had about 8,000 proteins, including cytokines and other mediators. The test that was used to analyze these samples was a glass slide-based antibody kit, and the aim was to analyze 8,000 target proteins, including mostly cytokines. These are the demographics. We had 10 eyes in each group, and the age and the sex were equally matched between the groups. And the results showed that there were a significant number of differentially expressed biomarkers with a false discovery rate of less than 0.1, the most being in the advanced versus control group. And it's very important in such large data sets not to take cytokines or individual mediators in isolation, but to consider them as a whole to look at any possible pathways that are standing out. So with an advanced to mild comparison, we found that multiple pathways related to immune activation were upregulated. In a mild versus control comparison, pathways related to vascular development, cell migration, and decreased proteolysis was upregulated. Now, this is a cross-sectional study, but we can, and ideally a longitudinal study is required to really say that this is linked to glaucoma pathogenesis, but we can extend and say that these may be involved in glaucoma pathogenesis. In an advanced to control comparison, there were several factors that stood out, including angiogenic factors such as angiopoietin, pro-inflammatory cytokines, immune modulators, and structural proteins such as matrix metalloproteinases. Now, just a brief discussion. We found that IGF-1R, the IGF-1 receptor, was significantly increased in advanced glaucoma, and this has been implicated previously in neovascularization and in thyroid eye disease, and this may be a new target that can be studied in glaucoma pathogenesis. Similarly, angiopoietin-1 recently was shown to be really involved in the formation of Schlemm's canal and its integrity, and knockout models had significant glaucomatous changes. That's another gene that can be studied in glaucoma pathogenesis. In conclusion, this study has identified clearly many pathways that are implicated in POAG pathogenesis as well as progression. Now the next steps would be to validate these findings. So this can be seen as a large study that is a starting point to further targeted approaches. To validate these studies in animal models will help us identify further mechanisms, especially with relation to vascular markers and angiopoietin, to rule out the effect of glaucoma medication, because many of these patients were on glaucoma drops. This can be done using in vitro techniques using TM cells and using qPCR to see if these same genes are upregulated, and to correlate the findings with clinical characteristics as well as OCT and visual field parameters. Thank you, and I'd like to acknowledge the funding sources and my team. Thank you.
Thank you, Dr. David. How do you plan to take this study forward? Like, what would be your next step of research in this aspect?
Yeah, Yeah, one is to, so this has given us a lot of pathways to work on, especially vascular markers such as angiopoietin and other, especially there are other parameters related to lymphatic formation. So the next step will be to isolate these findings in animal models, so we can create knockout models of these genes and study that specifically. And the second, I would say, is to really study the effect of glaucoma medication, because that can affect the cytokine profile in that aqueous humor. So to really make sure that this is not an effect of the treatment that we are seeing, that's another step.
Thank you. Okay, before winding up, I'd like to mention there are two more absentees are there. By any means, they are here, Dr. Manisha Barik and Dr. Sushil Oja. If not, I request all the presenters to come to the dais for a photograph with our chairpersons.
They are not there only.
So why not us? Let us have the photograph. I think you are a presenter. This session?
Whoever is there. Now is the photographer.
Yeah, photo session is also important. Yeah.
Going to present our work on evaluation of surgical outcomes of 360-degree goniotomy in primary congenital glaucoma. So primary congenital glaucoma, it accounts for 0.01 to 0.04% of the total blindness worldwide, and the definitive surgical management options are goniotomy, trabeculectomy, and combined trabeculotomy and trabeculectomy. Now goniotomy is preferred to other surgical procedures. Why? Because it is minimally invasive, it spares the conjunctiva, and though there is no bleb related complication, also it is cost effective. So the traditionally angled surgeries which have been described, they open up around 1/3 of the angle in one step. So multiple steps might be needed to open up the entire angle. So we perform this prospective analysis on this 360-degree goniotomy. Now infants who presented to our congenital glaucoma clinic, they were screened, and 52 eyes of 32 patients were included who were having primary congenital glaucoma of age less than 2 years and having a good corneal clarity, which permits us to see the angle and perform the procedure. Now patients with dense haze, secondary glaucomas, patients were not willing to give consent, and age criteria, they were excluded. Now that 360-degree goniotomy is performed, here we can see that with the 24 gauge bent needle goniotomy, nasal goniotomy is being performed, and as we can see through the lens that there is, as we are opening up the angle, there is falling back of the iris. Now we shift the position to the other side, and now we perform the temporal goniotomy, following which the irrigation aspiration is done and the ports were hydrated and sutured. So now we can see the gonioscopic view of the angle in the children. Before performing the goniotomy, there we can see that there is anterior insertion of the iris, and post goniotomy we can see that there is falling back of the iris with opening of the cleft. Now these children were followed for a period of 12 months, every 3 monthly, and the intraocular pressure and the number of anti-glaucoma medications were recorded in each follow-up. Success criteria is defined as absolute success with IOP less than 18 mm of mercury on no medication, and qualified or IOP less than 18 with on less than equal to 2 anti-glaucoma medications. Now coming to the results, here we see there is a table showing the pre-op and the post-op IOP. Post-op at 3 months, 6 months, 9 months and 12 months. We can see that there is a significant reduction in the IOP, and the mean IOP decreased at 12 months with a significant p-value. Also, the number of anti-glaucoma medication has also significantly reduced at 12 months follow-up. Baseline characteristics at the pre-op were also recorded, such as the age at presentation, the intraocular pressure, axial and corneal diameter, anti-glaucoma medication, the cup to disc ratio were also recorded. Here we can see there is a chart which shows the anti-glaucoma medication and the intraocular pressure. This bar graph shows the anti-glaucoma medication. We can see that there is significant reduction and it stabilizes at around 12 months. Also the intraocular pressure follows the same trend from the pre-op and the post-op 12 months. Now we tried to find out any correlation between the pre-op IOP and the cupping and axillin. However, no significant correlation was found. The forest plot shows the same. Now we found the success rate. The complete success rate was 40% and qualified 48, bringing to a total success rate of 88%. Kaplan-Meier survival analysis was also plotted, and it shows that there is a stability in the curve at 12 months of more than 75% survival rate. Now additional surgery was required only 9.61% eyes, where trabeculectomy was performed, and complications was seen in 19.23% of eyes, which was transient hyphema, and it was managed conservatively well. Now why goniotomy? Because it is a conjunctiva sparing surgery, shorter duration of surgery and post-op recovery. It has lesser complication, also cost effective. Then why 360-degree goniotomy? Because the aqueous outflow is not symmetrical. So we perform 360-degree goniotomy and open up the entire angle, and there also we can avoid the need for multiple anesthesia and reduce the parental stress, and cost effective in a country like ours. So why not other procedures? So there are studies which have compared like 360-degree trabeculotomy versus the partial trabeculotomy. They have also shown good result, but there is an additional cost of the microcatheter. Why not trabeculectomy? Trabeculectomy has manipulation of the conjunctiva. There is use of antimetabolites, so it can lead to bleb-related complication and vision-threatening complications. This leaves a very small window for performing further interventions. These are various studies which have shown which supports the documentaries. Finally, I would like to conclude with saying that patients with pediatric glaucoma is a challenging case, and it requires multiple surgical procedures. So if we perform goniotomy, and our study has shown that there is a significant reduction in the IOP and the anti-glaucoma medication in the long term. So we can perform this where entire angle is treated at once, and this also buys us time for further surgical interventions if it is needed, and also better for the parents and the children. Thank you. Thank you.
Thank you. Very nice study. So just we need a clear cornea, you're saying, no?
Yes, ma'am.
So that means most of these cases will not be the very severe cases who have
moderate glaucoma,
and
yes,
which we usually see in this country.
Yes,
Yeah.
ma'am.
It is
Clear
mostly
enough
for
so
the
that
lower
yes, ma'am, so that we
cases.
can see the angle and perform the procedure. Yes, ma'am.
Goniotomy has been around for maybe 50 years.
Yes, sir.
So what is new in your study?
Sir, in our study, goniotomy has been new, but those are traditional surgeries which they performed only around like the partial procedure, like around 1/3 of the angle they opened up. But in our surgery, we tried to perform 360-degree goniotomy, where we can open up the entire angle, sir. So we can do it in one go only.
How was the observer error ruled out for all the measurements over all these time points? Was
Ma'am,
it the
single observer.
for all the measurements,
Yes.
all the time
Yes, ma'am.
points?
Single observer. I performed the evaluation under anesthesia, and we ensured that for those patients, the single observer is done. So
And
we
what
ensured this.
anesthesia?
Ma'am?
Which anesthesia?
Ma'am, inhalational anesthesia was used, ma'am. Yes, ma'am.
Okay, thank you,
Thank
Dr. Ekta. Next, I'd like to call Dr. Mahideen Abdul Qadir sir to screen myocilin mutation in a large South Indian family with early onset.
Good afternoon, sir. So I'll be talking about to screen myocilin mutation in a large South Indian family with early onset JOG and POG. These are my co-investigators along with me. And the background of the study is we have 26-year-old female high school teacher who presented to OPD, busy OPD with 1 year duration of defective vision. Her presence is 50 in both eyes, and she had 6 illnesses in people, a poignant cup, open and glaucoma. We were stunned to see her so big, cupping with pallor and all kind of things. So we pulled her brother who came along with her. We found her pressure is 54 and 46. He didn't have any complaint, but upfront pupil defect and poignant cup in both eyes, and he had a big fundus picture of this patient. Then we thought the family history, they asked us to a family history, glaucoma mother, grandmother. Then we thought we something had to do for that. So we went to the village called Kaladali, which is 100 kilometers from Madurai, Ramnath district, literacy rate of 70%. We took a slit lamp, we took a tone up pen, we took a gonioscopy, we in a comprehensive examined at the camp site itself. So we also took a blood sample for genetic analysis. We had a counselor, we had a photographer who can take the handheld disc photograph and all that done the same day. This is a part of a World Glaucoma Week done a few years back. So now the objective is to screen a myosin mutation in a large South Indian family with the early onset of juvenile glaucoma and the early onset primary open glaucoma. So we have done, I told you, all comprehensive exams, even gonioscopy is done at that the base visit. And we all taken the patient with open angle glaucoma excluded from the study. And we look at the younger age group in PAOG, age less than 40 years, and age diagnosis is 31 years. Gender proportion is equal in all the three groups. And look at the IOP. IOP is around 29 millimeter, 29.2 millimeter, especially in a PAOG compared to PAOG suspect and control is significant. And complete is 0.87 in PAOG compared to a PAOG suspect and PAOG control is PAOG less than 0.001. So the bar diagram again shows the PAOG has a higher IOP and lower CCT and higher CD ratio. So we also compared clinical profile of the proborn, offspring, and sibling. We found out the proborn and siblings are severely affected, whereas the offsprings are unaffected, but they are myosin positive. So these are the pictures of the patients of the A and B or C are patients of proborn brothers and sisters, and D and E are proborn's children. So the rate of progression among these people, the proborn and siblings, are minus 2.86 decibel per year in a visual fields. The age of diagnosis at the age of 20 to 30 years, especially in 40,000 people are diagnosed at the age of less than 30 years. So the blood samples were affected. All the patients were written consent. We taken for DNA extraction and also bidirectional sequencing was done for myosin gene mutation, and whole sequencing was done for the patients of myosin negative, especially in POG suspect patients. So then the researcher came to the campsite. So the Dharmalingam and Barnitharan, the professor from the Aravind Medical Research Foundation, they came to the campsite. So we took and done a pedigree. It was surprised to see a pedigree. The proborn, the arrow mark, she is a positive for myosin. Two brothers are positive for myosin. A sister is positive for myosin. A mother is positive for myosin. Grandmother is positive for myosin. Her mother's brother is positive for myosin. The whole family is positive for myosin with high intraocular pressure. So out of 40 members we screened for myosin mutation in axon 3, we found out that 20% people are positive with an N460K in axon 3. And out of 20 people, 15 were PAOG and 3 were JOG successful, 2 were control. Youngest one is at 10 years. And there are 18 mutation people age of more than 10 years. 70% have disease percentage of 94%. And the POG suspect and JOG suspect 2 carry a mutation. The carry mutation, the axon 1 of the myosin, the common variant, and 2 control will be slowly closely followed up. So our study is found that N480K alteration is characterized by high intraocular pressure and younger age of disease. And nearly 80% of patients need a filtering surgery to control intraocular pressure. And whole sequence examining done for this patient who appears suspect, we identified L432V in a CYP1B1 gene and R76K in a myosin gene. So further screening of this polymorphism in this close relative reveals the inheritance in the family and is associated with the POG suspect. And our conclusion was JOG had high intraocular pressure and the female is highly predominant. In a POG, the female is 1:1 and the IOP is around 20.57. To conclude, a strong familistic glaucoma with high IOP and younger age of persons like our study warranted genetic testing for myosin gene mutation, especially in our setup. Younger carriers identified in the study need to be followed carefully the symptom of initial intervention, emphasize the importance of screening of myosin gene and other gene variant in family-based studies. To conclude, JOG patients in the myosin mutation that reportedly have high intraocular pressure and early onset, a left anterior result in visual impairment, and screening of myosin mutation among JOG patients of this family helps in detect disease early. Early detection will allow better therapeutic intervention. Thank you.
Thank you. Thank you.
Thank you.
So I think now Vaishali is there. Yeah, please come. So Vaishali is going to present ab interno Schlem's canal viscodilatation and trabeculotomy by Omni system in open angle glaucoma.
Good afternoon, everyone. I'm going to talk about the Omni surgical system, which is an MITS device which has been sort of developed by Sight Sciences to target 3 different sites of
outflow restriction at the trabecular meshwork, at the Schlem's canal, and at the distal collector channels. It is a device that can perform ab interno circumferential canaloplasty and trabeculotomy with a single handheld system. We are presenting here the retrospective analysis of the first 30 eyes that were performed at our center between August and December 2022 by a single surgeon. A target IOP was set for each eye preoperatively. Blood thinning agents were not discontinued preoperatively. The postoperative follow-up visits were at day 1, 1 week, 1 month, and every 3 months thereafter. All the anti-glaucoma agents were stopped after the surgery, and if they were reintroduced one by one if needed, if the intraocular pressure was not satisfactory for the stage of the glaucoma at the other visits. The case notes were then compared for pre and post-op vision, pre and post-op intraocular pressures, pre and post-operative number of medications at each visit. Any complications were also noted at each visit. Now, of the 30 eyes, 11 eyes underwent standalone canaloplasty and trabeculotomy, which we will call OMNI for simplicity's sake, while 19 eyes underwent canaloplasty with trabeculotomy combined with cataract surgery, which we'll call phaco-OMNI. For the purpose of this review, complete success was defined as any eye that reached the target intraocular pressure without any anti-glaucoma medications. Qualified success was defined as any eye that did the same with anti-glaucoma medications. And failure was defined as any eye in which the intraocular pressure could not be controlled or it needed some other surgical intervention. So this is the demographic data for our two groups. Most of the patients were in the 7th decade of their life. The age range was quite similar in both groups. Males were more common on both groups. The group A had the more severe glaucoma. It also had more average pre-op medications, and it also had more pre-op glaucoma surgeries before the OMNI was tried on compared to group B. Primary open-angle glaucoma was the most common diagnosis between the two groups, followed by secondary open-angle glaucomas and ocular hypertensions. We also had some normal tension glaucomas and some angle closure glaucomas, but they were very little. The mean baseline intraocular pressures in group A was 22 millimeters of mercury, which reduced to 13.37 millimeters of mercury at 12 months. The same baseline pressure for the group B was 18.31, which reduced to 13 millimeters at 12 months. There was a significant reduction in the number of medications in group A from 3.5 at baseline to 1.27 at 12 months. Similarly, for group B, there was a significant reduction from 2.8 at baseline to 0.5. So one eye out of the 19 eyes was on medication at 12 months. All of the eyes bled a little intraoperatively, but only about 3 eyes in standalone canaloplasty and trabeculotomy, and about 10 eyes in the combined group had blood clots in AC on day 1. Layered hyphema, less than 2 millimeters, was present in 7 eyes, which resolved on its own without leaving any sequelae or needing any active intervention. Intraocular pressure spike more than 10 millimeters of mercury from baseline was seen in 2 eyes, was managed conservatively. No eye suffered any visual loss, which could be attributed to the procedure itself. So success rates at the end of 12 months was 39% reduction from baseline in standalone OMNI group and a 29% reduction in the combined group. One eye needed glaucoma implant, so it failed in the standalone group. So this is just a comparison of the cataract with the OMNI group, because this was more comprehensive. We found 2 other studies. The Gemini study, which was a prospective study for canaloplasty and trabeculotomy with cataract surgery, and Habash et al., which have presented their 12-month outcomes of combined GAT with ABIC, which is with cataract surgery, which is something similar to what the OMNI does, but not exactly the same. Intraocular pressures and other success rates were comparable, but we had less people in the more than 20% reduction group, and that's possibly because we had a lot of ocular hypertensions and normal tension glaucoma groups. Limitations of our study are retrospective analysis and loss of data at 12 months. However, it does show us that combining canaloplasty with trabeculectomy and cataract surgery could be a good management strategy for mild to moderate glaucoma. It could still be offered for patients with advanced glaucoma because it has less risk and less surgical time is needed to do it, and it does cause a reduction in the medication load. But obviously, better studies with more follow-up and with more number of patients are needed to validate these outcomes. Thank you. And that's the clinic that we were.
Thank you. So
Thank
thank you,
you,
Dr.
said-
Vaishali. I just wanted to know, was there any subgroup analysis done with respect to the different types of glaucomas?
There were very few patients in
Yeah.
each madam, so there was just one angle or one NTG. So
Yeah, but
it wasn't very-
overall, any clinical difference that you found, especially with regards to pseudo exfoliation?
Again, there were only 2 patients,
Yeah.
so we have not
No
made
correlation.
any this
No
thing, but it was
comparison.
sort of generalized.
Okay.
Yeah.
How did you set the target IOP?
It was based on the age of the patient, the visual field index, how much was the glaucoma, what was the life, this thing. So based on that, we set up a target IOP.
No absolute number.
I'm sorry.
Yeah.
No absolute number. So this was a retrospective study. So we just started doing the surgeries, and for each patient, as we do, we expect it to go to a certain level, for halting the progression of glaucoma or reducing the progression. So that was how it was done. And then we just thought, okay, let's see what's happening in our center with the first 30 patients at least. How are we getting on with it? So that was just it. So there was no fixed reduction or anything. The data that I showed was just because the other studies have said those parameters, less than 18 millimeters of mercury or more than 20% reduction. So that was just to compare with, to see how our data fared with those studies. But no number was set before. It's
So
a retrospective study now.
A lot of patients developed hyphema.
Yes.
So, but the vision did not drop.
No. I mean,
Not
the
on the
vision
first day.
fluctuated in that period, but there was no sequelae afterwards. It just, sometimes you have a clot, or you sometimes have dispersed hyphema, but that resolves on its own. So by 4 to 6 weeks, there's nothing there.
But initially in the first week, you're saying hyphema is there and vision may
Mm.
have reduced, fluctuated.
Yeah, just fluctuation. I mean, no significant loss of it, no irreversible loss of vision, which could be attributed to the procedure.
So do you think these antiplatelets could have been stopped or?
We didn't really have a problem at 4 to 6 weeks, and even at 12 weeks, there's nothing really there. So they could have those antiplatelets for some other, bodily problems, which could be more severe than their glaucoma. So, I think we got away with it so far. But yes, that should be kept in mind that they could bleed a lot. One of those could be, quite
So we
big,
have
yes.
to tell the patients before the surgery.
Yes,
that
we
this
do
may
tell them
happen,
that, this is something that is cutting it from inside, so do expect some bleeding. And of course, if they're on blood thinners, we do sort of tell them that that's what's going to happen.
Thank you.
So proper counseling
You had
is
no incidence of secondary hemorrhage, like you saw the blood come immediately post-operative day, some clots were there and they disappeared. But did you have a patient who had no blood on first
No.
and second post-operative day,
No.
bled later?
No.
Okay, thank you, Dr. Boshali. With this, we are coming to the end of the session. Again, I request our participant to come to the dais for a photograph with the chairpersons, please. 3 of you, please come. And my sincere thanks to the co-chairs who are with us. Thank you so much.